Hi everyone, I'm Siti Chandra. I'm with Bala. Is in this workshop, the airway clearance workshop, and I will continue the next session. This is the B1 section, and I will telling about this secretion management with intake cuff and introducing the inspiratory muscle trainer and the positive and expiratory pressure management. Those that I will already mention is the tool for respiratory muscle training, that we know that if we are not training the muscle, especially the respiratory muscle in the critical illness, so there will be a dysfunction of those respiratory muscle, and there is a diaphragm dysfunction in that condition. By using the respiratory muscle trainer, we train the respiratory muscle and we can get the increase of the inspiratory muscle strength. Then we can managing the cuff, removing the airway secretion. Also, we can train the endurance, relieving dyspnea, and increase the quality of life. Let me come first for the inspiratory muscle training. The inspiratory muscle trainer using this one in the picture is the threshold IMT that usually we use it. From this case, in the prolonged mechanical ventilator, that we all know that there is an impair of inspiratory muscle strength and endurance. The dysfunction of the diaphragm and the sarcopenia, the atrophy, can occur rapidly and is detectable in patients just after 18 to 69 hours, 69 hours of control mechanical ventilator. In mechanically ventilated patient, for more than 24 hours, the diaphragmatic dysfunction is associated with the prolonged weaning. So over the past 15 years, the inspiratory muscle training, using the inspiratory muscle trainer, has emerged as a promising treatment for ICU patients. For the inspiratory muscle training, using the inspiratory muscle trainer itself is a targeted strengthening of the inspiratory muscles through the application of resistance during the inspiration. At that tools, we can provide a resistive loading. Then this is like a whole body training with the threshold. So the training resistance is ranged in several number between 9 to 41 centimeter H2O, and it's depend on the inspiratory power strength that we already measure before with the respiratory muscle measurement. This is a single patient use, so this tool is only for one patient, and this does not require maintenance and specific cleaning. So the patient is aware and the patient is have an intake cuff, so we can train them to do inspiratory with these tools while they were inhale with training resistance. For ventilator-dependent patient, one of the literature that mentioned the ICU patient with ventilator-dependent invasively ventilated more than 7 days is considered that get the inspiratory muscle training. The patient will measure first, and the patient must be hemodynamically stable because it can change the intrathoracic pressure, so may affect to venous return, and this patient must be able to do a spontaneous breathing on ventilator. Our goal is to assisting them to wean from ventilator, and also for secretion management, because the increase of the strength of the inspiratory muscle also will increase the ability of the muscle to do the secretion management and increase the cuff. That will mention more detail with Mr. Bala. The assessment before we start the inspiratory muscle training. This picture, we know that this tool is called micro RPM. This is a respiratory power meter strength that we use. There is so many tools that we can use to measure the muscle strength, but in this, usually we use is the micro RPM. So we will determine the patient baseline maximum inspiratory pressure, or DMIP. From DMIP, we know how many centimeters H2O, the power of the inspiratory of the patient. So we know the maximal, and we can train the gradually for this patient as tolerated of that patient. We also can measure from the ventilator setting menu about the inspiratory force. The terminating criteria for the IMT patient, we can see in the blood pressure. Also, you know that we have to maintain that there is no alteration in blood pressure more than 20% of the resting. Then there is no new arrhythmia, there is no oxygen desaturation more than 10%, and the others that might be suspected about pneumothorax. So if we do more than 40 centimeter H2O, sometimes it's provocating the pneumothorax. So we have to deal with the main problem of the patient when they are entering the critical ill patient or the intensive care ward, is that has some organic factor or from the disease that might cause pneumothorax because of fragile of the parenchyma of the lung. So also we also think about the agitation risk of this patient within the intensive care unit. So we also for extremely weak patient that we have to maintain first, and we have to do gradually for the IMT application from this patient. We can start with the patient from less than 18 centimeter H2O, and we can increase gradually. Just ask the patient to try to this IMT with a few breaths, the lowest setting, then we can gradually increase. The timing to use the IMT also crucial for those that we give the rehabilitation intervention for adjusting the weaning process. And the rehabilitation intervention for secretion management to increase the power of the inspiratory muscle. So we also have the electronic inspiratory muscle trainer. Also, this is like a taper flow resistant load. This is can be set with the gradual resistance, and this is this device is more predictable, the gradual increasing of the MIP, and can measure the performance all about the pulmonary function, the tidal volume, and the energy of breathing during the training session. And these tools is more expensive than the ordinary tool that we use, is like regular respiratory power meter, just like micro arm that I've already mentioned before. The independently breathing patient, from the patient selection, they are already alert, medically stable. Also, we have no excessive pain or dyspnea and able to maintain an adequate lip seal. The contraindication is severe burn around the lip and mouth, then already established pneumothorax, or this patient perhaps has possibility to get a pneumothorax that was multiple play, or sometimes with fragile lung, with the fragile parenchyma of the lung. We cannot give this inspiratory muscle trainer with the excessive load. And so spontaneous rib fracture also we cannot give it, and this patient is undergo about less than 12 months of the lung surgery. So after determine the baseline of the MIP, the maximal inspiratory pressure, then we can go into trainer and we can try the patient gradually one by one, and we can give the training doses, start daily training when the office hours, then they will get a weekend off, and we just evaluate the strength. Usually the strength is gradually increased and every weeks, and in the 2 weeks we can see the improvement, and the strength will basically we can see the improvement is significant after more than 2 weeks. During the IMT therapy, we still has to monitor and re-monitor and also extra aware about the oxygen saturation, because when we provocating breathing, so inspiratory, so it will, with patient with mucus secretion, the mucus will moving because of the breathing pattern also, and this is one part of the secretion management. So there is a risk of desaturation. So you have to stay alert about the patient saturation at the vital sign. And we have to know if there is a sudden desaturation. Determine the load of the MIP, about 50, half of this DMIP, about 50%, and we can increase gradually. And for very perhaps a patient with geriatry or some of condition, we can start from lowest percentage of the MIP. We start from the few repetition, this is 5 set or 6 gradually, or we can, as a patient, tolerate until they can adapt it with this equipment, and we can increase gradually. The second part that I have to tell about the secretion management in intake cuff with the tools that we call, after IMT, we train the inspiratory, we go to the expiratory trainer. So we go to the positive and expiratory pressure or PEEP. There is so many modality about the expiratory trainer. So besides PEEP, we have another tools that use the N expiratory approach. So we have also flutter device. We have also a capella that you for the positive and expiratory pressure. But at that time, I will discuss about the positive and expiratory pressure or PEEP This PEEP can be achieved by breathing out again resistant. So we have to exhaling, breathing out through this device. This device is a threshold PEEP for mucus clearing device. So train the expiratory muscles. Usually expiratory, exhaling is usually passively after an inhale. So not train well in the daily the routine. So usually we train more for the inspiratory. But if we train the expiratory also, it will help for the secretion management. And we expect that the functional residual capacity is and tidal volume when we apply this technique will be increased temporarily. And the resistance of this device, this device just like increase little or silt because of this push slip that we use for push slip breathing. So if we measure the maximal expiratory pressure, also we measure the with the micro RPM we can measure the MAP. Besides we can measure the MIP. So we can determine the power of how many load that we give, and we try the patient to use this device. The combine using the PEEP with the other expiratory force expiratory modality also will make a better outcome for secretion management. For this mechanism of exhaling in creating a positive and expiratory pressure is like when we are doing the push slip breathing. The breathing again resistant, just like we ordinarily use in COPD patient, use the PLP. So some patient use blowing bottle for create resistance also for creating the P positive and expiratory pressure. But if we use the PEEP device, it's gonna be more measurable, and we know the exact amount of load that we can record for this patient when we gradually increase the load. This is the use of PEEP in airway clearance. So we can use in any kind of secretion retention and impair of our patient with hypersecretion problem, impair mucociliary or cough ability. So because they were increasing the positive and expiratory pressure, also they can increase the or train the expiratory muscle also. So they can do both for those tools. And so many technique for the airway clearance. Bala will tell more detail about those technique, and I'm just introducing the IMT and also the PEEP. This is the slide of how they are doing the huffing and doing the coughing. And this is the schematic drawing while a healthy subject is comparing with this obstructive patient with hypersecretion problem who who record with this airway clearance technique in cycle to increase the functional residual capacity during their using the PEEP. This other technique to for using PEEP also. The coughing and evacuating the sputum. It is also using the oscillating PEEP. It's oscillating at the end of respiratory. We can use like a Pella device, the flutter device. This is also the oscillating PEEP. Oscillate while breathing to provoke it, coughing and evacuate the secretion. This is the forced expiratory flow volume in cystic fibrosis patient, or from there is a oscillation while this loop using a PEEP and this therapeutic part to mucus clearance. The contraindication is similar, because if there is pneumothorax, we can use so many aggressive modality. So we still have to measure about, again, the vital sign, look at the saturation of the oxygen. If the patient has a previous chest x-ray, we have to look at the chest x-ray. If the patient has a CT scan, we have to look at the previous CT scan if the patient has tendency to get a pneumothorax. So the side effect during treatment, perhaps dizziness. If we can measure also the CO2 with use capnograph for monitoring from the ICU panel, so we can see what happened with the CO2. Is this any increasing CO2 or decreasing? So we have to know that this patient is affected by the blood gases. Okay, thank you. And this is my session from the B1 about the secretion management and introducing the IMT and the PEEP. And the next session will be continued by Bala. Thank you.